Welcome to the USA Health Claim Coach YouTube channel. My promise to you in every single explainer on this channel is this. By the time this lesson ends, you will know exactly what to do next. No confusion, no guessing, no wondering if you filled something out correctly. Just clear, confident, step-by-step guidance from start to finish. That is what we do here every single day. So settle in, have your documents ready, and let's walk through today's lesson together, one step at a time. We're going to master the CMS 1450 and the EDI 837I, and we're going to do it right now.
Okay, here is our game plan for today. First, paper versus electronic claims. Second, the ASCA exceptions. Third, step-by-step claim filing. Fourth, proving medical necessity. And finally, number 5, beating common reason codes. Let's dive right in.
Section 1. Paper versus electronic claims.
So let's compare our two main tools of the trade here. On one side, we have the old reliable CMS 1450, which you probably just call the UB04. Now, this traditional paper form is still accepted by some payers, sure, but it requires manual handling. And you know what that means, right? It significantly slows down your processing time. On the flip side, we had the EDI 837I. This is the modern electronic standard, and honestly, it's a real game changer. The absolute biggest advantage of the 837I is the error management. It literally has built-in edits that actively catch your errors before the claim is even submitted. So it's faster, it's way more accurate, and it's heavily preferred by most insurers today. Now, you might hear some incredibly dense technical jargon thrown around the billing department. Things like NCASC X12N837I version 50110A2. Okay, take a breath. Do not let that alphabet soup intimidate you. This is simply the current, standard HIPAA electronic format used by institutional providers, like your skilled nursing facilities, to transmit healthcare claims. That's the whole shebang. It is just the secure, digital language that your computer systems use to talk to the insurance companies. Simple as that.
Moving on to Section 2, the ASCA exceptions.
Okay, so Medicare generally requires all your initial claims to be submitted electronically. But there are a few rare exceptions where paper is actually allowed, known as the ACA waivers. You can still submit that paper CMS 1450 if your facility has fewer than 25 full-time equivalent employees and you're billing your MAC. Another big exception, roster billing. This happens when mass immunizers submit one single form with an attached roster of patients who, say, got a COVID-19, flu, or pneumonia shot. But listen to me on this one. Unless you explicitly meet these specific waivers, electronic filing isn't just recommended, it's mandatory.
All right, Section 3, step-by-step claim filing. Let's open up the playbook.
Now we're getting into the nitty-gritty. Getting the data exactly right across these 3 specific steps is absolutely crucial to prevent instant payment delays. Step 1, gather patient info. You need to capture their exact demographics and insurance IDs, whether we're talking Medicare, Medicaid, or private insurance. I can't stress this enough, a single typo here will stop your claim dead in its tracks. Step 2, enter the provider details perfectly. We're talking about your facility's NPI, the tax ID, the complete physical address, and the attending doctor's specific name and ID number. And finally, Step 3, document the services. You have to record every service provided, nursing care, therapy, room and board, and properly link that care to the correct revenue, HCPCS, or CPT codes. This is what translates the amazing care your facility provided into the exact language the insurance company actually understands and pays for.
Let's look at Section 4, proving medical necessity.
So let's shift from offense to defense for a second. You could have a perfectly coded form, but it's still going to get denied if the care wasn't justified. There are absolute requirements for Medicare coverage. To secure payment, the item or service must fall within at least one benefit category, it cannot be specifically excluded, and most importantly, it must be strictly reasonable and necessary. And how do you prove that? With actionable, highly specific documentation. When the Medicare review contractors come knocking, your compliance documentation is your absolute only shield. Your staff has to detail exactly why the care required a skilled professional. Because listen, if the complexity of the care isn't clearly written down in those notes, well, in the eyes of the payer, it simply didn't happen.
And finally, Section 5, beating common reason codes.
Okay, this is where we prevent the headaches. One of the most frustrating traps in all of SNF billing is reason code 6, insufficient documentation. And this brilliantly illustrates the problem, specifically getting hit with codes like SN700 or SN701. This means you just got slapped with the denial because the paperwork was either completely insufficient or just entirely missing for the services you billed. It is 100% preventable, yet it stalls cash flow for facilities every single day. Let me rapidly guide you through a few more administrative traps you absolutely need to have on your radar. SN00, that means you didn't prove the strict 3-day qualifying inpatient hospital stay prior to admission. SN100 hits when a patient is admitted more than 30 days after their hospital discharge without a documented predictable need. SN200 is benefit exhaustion, meaning there just simply aren't enough coverage days left for that patient. And the SN300 series? Oh man, that is the absolute nightmare of missing, unsigned, or late certifications and recertifications. These are pure preventable administrative errors that literally cost facilities thousands and thousands of dollars. Now, while those previous codes were mostly administrative hiccups, what's really interesting about this slide is reason code 7. This one directly attacks medical necessity. It actively questions whether your facility actually needed skilled personnel to deliver that care in the first place. A prime example of this is code SN800. If you get hit with an SN800, auditors are stripping away your reimbursement because your notes completely failed to prove that the rehab services could only be performed safely and effectively by skilled personnel. Think about it from their perspective. If your documentation makes it look like just anyone could have done it, Medicare is certainly not going to pay premium skilled nursing rates for it. Your documentation has to clearly, vividly paint the picture of complex medical need every single time. So, I want to leave you with a question to really think about. Are your facility's documentation practices truly bulletproof against these reason codes? After walking through this step-by-step guidance today, I challenge you to audit your own processes the second this explainer ends. Go check your CMS 1450 workflows, ensure your EDI 837I data is being flawlessly gathered, and make absolutely sure your medical necessity documentation leaves zero room for doubt. Take this playbook, share it with your entire team, and put it to work. Thank you so much for focused learning with us today, and I will see you in the next explainer.